Diabetes mellitus is a disorder of abnormal glucose control in the blood resulting from insufficient production of insulin or a relative resistance to the effects of insulin on cells. It's a prevalent medical problem affecting approximately 6% of the world's population, with an estimated 429 million diabetics by the year 2030. Over 95% of these patients will be type 2 diabetics. The diagnosis of diabetes is made by a fasting blood glucose level greater than 126 milligrams per deciliter, or 2 random blood glucoses over 200 milligrams per deciliter, or 2 measurements of hemoglobin A1C levels greater than 6.5%. This chronic disease has devastating systemic effects if it isn't well managed as a result of damage to cells sensitive to the effects of glucose. One of the most crippling effects of diabetes is vision loss. Within 10 years of diagnosis, 80% of diabetics will have at least some manifestation of diabetic eye disease. Permanent vision loss from diabetes is one of the leading causes of blindness in the United States. The structure in the eye that is most sensitive to elevated blood glucose and most relevant when it comes to the effects of diabetes on the eye are the retinal blood vessels. The mechanism by which blood vessels are affected in the retina is well understood. One of the key players in diabetes is a cell called the pericyte. These cells are found wrapped on the outside of endothelial cells of the blood vessels. They help to maintain the integrity of the vessels by serving as a sealant that prevents leakage of fluid, blood, and proteins into the surrounding retinal tissues. Pericytes are very sensitive to elevated levels of glucose, which gets converted to sorbitol deposits. As they die, the blood vessels in the retina lose their integrity. They can become leaky, and they can balloon out in certain areas, which we call microaneurysms. As a result of leakage into the outer plexiform layer of the retina, the otherwise dry retina becomes filled with proteins which are bright yellow in color, which we call hard exudates. Fluid also leaks, particularly in the macula, which we call macular edema, and blood can leak as well, which we call dot blot hemorrhages. All of these get in the way of light reaching the photoreceptors, ultimately leading to distortion and blurring of vision. The ability of blood vessels to deliver oxygenated blood to the retina becomes compromised as well. The reason for this goes beyond the fact that the vessels are leaky and incompetent. Patients with diabetes typically also have poorly controlled hypertension. Blood vessels in hypertension usually become narrow over time. A narrowed vessel, in combination with a leaky vessel, is a double whammy, preventing the delivery of oxygen to structures that desperately need it. The nerve fibers found on the more anterior or superficial retina may also infarct, creating cotton wool spots. And blood vessels in this layer may rupture, leading to the formation of the classic flame hemorrhages. The vessels could also locally dilate, becoming microaneurysms. Clinically, we consider these changes part of non-proliferative diabetic retinopathy. As the retina starts to starve for oxygen, it releases an SOS signal in the form of a molecule called VEGF, or vascular endothelial growth factor. VEGF begins working with the best of intentions to come through by creating new blood vessels in the area of ischemia so that oxygen can be delivered. Unfortunately, these new blood vessels grow everywhere in the eye. Vessels along the iris, which we call neovascularization of the iris or rubeosis iridis. New vessels could also form in the anterior chamber angle, i.e. neovascularization of the angle. This can block the egress of aqueous from the eye. The pressure within the eye goes up to very high levels, potentially causing significant vision loss from damage to the optic nerve. We call this neovascular glaucoma. The abnormal blood vessels also grow along the optic nerve, which we call neovascularization of the disc. Vessels could even grow along the retina itself. These blood vessels are extremely incompetent, as they leak blood and fluid. This fluorescein angiogram demonstrates the abnormal leakage from these vessels into the retina. This causes further vision loss. Additionally, blood from these vessels can leak outside of the retina into the vitreous cavity, creating what we call a vitreous hemorrhage. This vicious cycle continues until the patient eventually goes blind, either from the glaucoma induced from blood vessels blocking the anterior chamber angle, or from the retina becoming ischemic or detached. These changes are consistent with proliferative diabetic retinopathy. Another ocular structure that is sensitive to changes in blood glucose is the lens. The lens undergoes anaerobic metabolism to help fuel its energy needs. High levels of glucose lead to the production of sorbitol, which serves as an osmotic agent. Acutely, this molecule can cause the lens to swell and can lead to blurred vision that resolves once blood sugars are more under control. The chronic changes in osmotic shifts over the lifetime of a diabetic makes them more prone to the development of cataractous changes to the lens, and they can sometimes take the form of a snowflake. The optic nerve, on rare occasion, can exhibit changes that look like papilledema. This is called diabetic papillopathy. It's a self-limited, sometimes bilateral disease that may affect both type 1 and type 2 diabetics. It's characterized by optic disc swelling caused by vascular leakage and axonal edema in and around the optic nerve head. Occasionally, it may be accompanied by intraretinal hemorrhages and hard exudates. Other nerves can be affected as well. These patients are vasculopaths, and they may suffer small vessel strokes within the cranial nerves, most commonly pupil-sparing cranial nerve 3 palsies or cranial nerve 6 palsies, that tend to carry a pretty good prognosis for spontaneous recovery within 3 months. Probably the most dangerous complication of diabetes is the development of mucormycosis infection in the orbit. When diabetics are in metabolic disarray, i.e. ketosis or hyperosmotic non-ketotic acidosis, they're most vulnerable to this fungus. The patient typically presents in an obtunded state with redness and swelling of their eyelids. You may find an eschar on the roof of their palate or in their nose. A tissue biopsy is necessary to confirm the diagnosis. The prognosis is poor, especially if the fungus obtained access to the brain through the cavernous sinus. The infection is treated with antifungals like amphotericin and aggressive surgical debridement, which invariably includes exenteration, which is removing all of the soft tissues in the orbit and the eyelids. Other involved facial structures are often sacrificed as well. Treating diabetic changes in the eye is directed at the structure that is involved. For all patients, the most important objective is to control the blood glucose with a hemoglobin A1C of less than 7%. It has been shown through the Diabetes Control and Complications trial that good sugar control reduces the development and progression of diabetic retinopathy, nephropathy, and neuropathy. Cataracts that are visually significant are removed surgically and replaced with an intraocular lens. Diabetic retinopathy management differs from proliferative, i.e. new blood vessel growth, versus non-proliferative, no new blood vessel growth. If the patient has macular edema that is affecting vision, most practitioners will inject an anti-VEGF agent into the vitreous, usually in 4 to 6 week intervals to help dry out the retina. Other options include a type of laser called focal laser that has tiny spots that are shot to parts of the blood vessels within the macula which are actively leaking. A fluorescein angiogram highlights these areas well. Proliferative changes in the retina are addressed by a combination of anti-VEGF injection and the use of pan-retinal photocoagulation. This is a type of laser with bigger spots that targets the ischemic retina outside the macula. The thought is that the laser kills the suffocating retina and the levels of VEGF secreted will go down, and proliferation will stop. Some patients will require retinal surgery to clear out blood from vitreous hemorrhage or to repair retinal detachments from the traction effects of the neovascular vessels. If there are proliferative diabetes changes in the anterior chamber angle, these patients will need an alternative way to drain aqueous and will require a glaucoma drainage implant. And they may also require glaucoma drops.